Um, Good morning. Today's class is about glaucoma. So coming to primary open angle glaucoma. So what is primary? We don't have any specific causes. Okay. So there is no obvious systemic or ocular cause of rise in the intraocular pressure. That is why we call it as primary. And there is open angle of the anterior chamber. It is also known as chronic simple glaucoma of adult onset and is typically characterized by slowly progressive raised intraocular pressure of more than 21 millimeters of mercury, optic disc cupping, and specific visual field defects. Okay. Coming to the etiological factors, in hereditary, it can be hereditary. In age, the risk increases with increasing age, particularly in the fifth and seventh decades. And race, it develops earlier and is more severe in black. Myopes are more predisposed than the normals. And diabetics. And cigarette smoking also increases the risk factor of open angle glaucoma, followed by high blood pressure and thyroid problems like thyrotoxicosis. Pathogenesis of rise in intraocular pressure. It occurs due to decrease in the aqueous outflow facility due to increased resistance to aqueous outflow caused by one can be age-related thickening and the other is sclerosis of the trabeculae and absence of giant vacuoles in the cells lining the canal of Schlemm. Coming to the clinical features, symptoms, the disease is usually insidious and usually asymptomatic. It can have mild headache and eye ache, but rarely the patient may notice a defect in the visual field. Reading and close work often present increasing difficulties owing to accommodative failure due to constant pressure on the ciliary muscle and its nerve supply. Therefore, the patient usually complains of frequent change in presbyopic glasses. And the patients also develop delayed dark adaptation. So most frequently, one of the main reason for frequent changes in presbyopic glasses is glaucoma. And only angle closure causes severe pain. So primary open angle usually causes mild headache and eye ache. These are the tonometers. The picture shows Goldman applanation tonometer, which is the gold standard. It is usually slit lamp mounted and it touches the cornea and gives two semicircular lines. The reading is taken when the two inner aspects of the two semicircular lines meet together. Okay. So usually it is the gold standard, but the disadvantages, it touches the cornea. Next is a Schiot's tonometer. And Schiot's tonometer is an old tonometer. So Schiot's tonometer also is a type of contact tonometer. So it here the Schiot's tonometer is kept on the cornea and the reading is taken from the scale in the Schiot's tonometer and corresponding readings are taken from the table which is given along with the Schiot's tonometer instrument. The other tonometers are Perkins handheld tonometer and tonopen. These are the recent things. Perkins is usually used for children while measuring the pressures in congenital glaucoma also in the examination under anesthesia in the operating theater. So as I told, all these were contact methods. So we are in the COVID era, and usually we go for non-contact tonometer, which will not touch the patient's cornea. Here, a puff of air is given, and the pressure is recorded from the puff of air, which intends the cornea, and thereby it gives the pressure reading. It is used for mainly for screening. However, the gold standard is Goldman applanation tonometer. Coming to the signs, usually three I say. One is intraocular pressure, and the second is optic disc changes, and the third is visual field changes. So IOP normal intraocular pressure is 10 to 21 millimeters of mercury, and whenever there is a diurnal variation, that is morning and evening reading, there is a diurnal variation of over 5 millimeters of mercury, then it is suspicious, and over 8 millimeters is mercury difference, then it is diagnostic of glaucoma. Whereas in the later stages, IOP is permanently raised above 21 millimeters of mercury and ranges between 30 to 45 millimeters of mercury. Then coming to the next thing is optic disc changes. So usually the retina optic disc is retina optic disc we see with the help of direct ophthalmoscope, and the second is indirect ophthalmoscope. Direct ophthalmoscope gives a magnified images, whereas indirect ophthalmoscope gives wide field of view. So usually it is used for peripheral retinal changes also. This is the normal retina, which shows the normal optic disc and the normal optic cup, and the retinal vessels are arising from the center of the optic disc and going superiorly, inferiorly, nasally, and temporally. Coming to the optic disc changes, we see the optic disc changes with the help of ophthalmoscope, which I already told. So usually the vertical cup, actually the normal cup optic disc and cup ratio is 0.3:1. So in glaucoma, what is happening is vertically oval cup due to selective loss of neural rim tissue in the inferior and superior poles, and sometimes there is asymmetry of the cups, so a difference of more than 0.2 between the two eyes is significant, and a large cup that is 0.6 or more, so that may also occur due to concentric expansion. Okay, so more than 0.6 is also due to concentric expansion, is also suggestive of glaucoma. And then we have splinter hemorrhages which are present on or near the optic disc margin, and there are pallor areas on the disc. So all these are the optic disc changes associated with glaucoma. Main is vertically oval cup, asymmetry of the cups, large cup more than 0.6, again splinter hemorrhages, and pallor areas. Coming to advanced, so what we saw was earlier defects. So coming to the advanced optic disc changes, we have marked cupping with a cup size of 0.7 to 0.9, and so when the cup size is increasing, you have thinning of the neuroretinal rim. So there is also thinning of the neuroretinal rim and nasal shifting of the retinal vessels, which have the appearance of being broken off at the margin, which is called as bayoneting sign. So this is one of the most important sign, and lamina dot sign, this is another most important sign. So what is lamina dot sign? The pores in the lamina cribrosa are slit shaped and are visible up to the margin of the disc. So when it is slit shaped and it is visible, we call it as dot. So lamina dot sign. Okay, and finally when every all the nerves are damaged and it becomes thin and atrophied, it leads to glaucomatous optic atrophy, which is called as cavernous optic atrophy. So this is called as cavernous optic atrophy. Specifically, the term is cavernous optic atrophy, which is mainly caused by glaucoma. So these are the optic disc changes, advanced optic disc changes, and these are the pictures showing lamina dot sign, which are the pores in the lamina cribrosa, which are seen clearly. And you also have thinning of the neuroretinal rim. So neuroretinal rim is thinned out. Coming to the arrangement of nerve fibers. So the nerve fibers are arranged in superior and inferior bundles, and according to the quadrant we call it as superior arcuate fibers and inferior arcuate fibers, and superior nasal and inferior retinal fibers. Okay, PMB means papillomacular bundle, that is from the, especially from the macular area to the disc, that we call it as papillomacular bundle. And it is the least it is highly resistant. Okay, it is highly resistant to the pressure changes. So this is called papillomacular bundle. Okay, so these are the arrangement of the nerve fibers. So why this arrangement is important? Because according to this arrangement only we have the visual field defects. So visual field defects, we usually mark it with the help of a tangent screen or Jerem screen. This is a black screen with white circles, and the visual field of the patient is plotted over the tangent screen or Jerem screen. Nowadays, we use automated machines which are called Humphrey field analyzer or octopus field analyzer. This is the older technique. So before that, we should know what is visual field defects. So it is called scotomas. So scotoma is an area of reduced relative or total absolute loss of vision surrounded by a seeing area. So this is called as scotoma. And what they in the exam they'll ask Jerem's area. What is Jerem's area? It is 10 to 25 degrees from the fixation, is called as Jerem's area on the Jerem screen. And we should also know the definition of scotoma. So here it is given. So it is an area of reduced relative or total absolute loss of vision surrounded by a seeing area. So these are the visual field defects. Usually it occurs in only one particular uh, uh, order. First comes is isopter contraction, followed by baring of the blind spot, and then comes your paracentral scotoma, and then sedal scotoma, and then arcuate scotoma, and then biarcuate or ring scotoma, followed by Roney's nasal step, tunnel vision, and temporal island of vision. So isopter contraction is generalized contraction. On the whole, it is contraction. Then barring of the blind spot is near the blind spot. So near the blind spot, and from there we have sedal scotoma. So sedal means a sickle-like. So it is the sickle-like scotoma. And coming to arcuate scotoma, arcuate means it is arc-like. So it is from the blind spot you develop one arcuate-like scotoma. So it is superior, we call it as superior arcuate scotoma. And when it is inferior, we call it as inferior arcuate scotoma. So when both are present, you call it as biarcuate scotoma or ring scotoma. So it forms a ring-like thing. So we call it as a ring scotoma. And when the superior scotoma meets the inferior scotoma, we have a gap in between, which is called as Roney's nasal step. Okay. And then comes your tunnel vision. Tunnel vision is only the center vision is tunnel like. Okay. So that is why it is called tunnel vision. And finally, you have a temporal island of vision. So this visual field defects happens only in this particular order. As I told earlier, so Jerem screen is an older method. Nowadays we use this charting is done with the help of a computers. So we call it as Humphrey field analyzer, or we have one more thing which is called octopus uh, analyzer. So whichever we want, we can use it, either Humphrey or octopus, and it gives the field defects like this. Okay, all the black areas or the field defects. Coming to provocative test. So what are provocative tests? Provocative tests are those tests which, so suppose we have a dilemma whether the pressure is increased or not, then we give the provocative test where the pressure will, which is on the borderline, will rise after some particular test. So first is water drinking test. It is based on the theory that glaucomatous eyes have a greater response to water drinking. So in it, after an 8 hours of fasting, baseline IOP is noted and the patient is asked to drink 1 liter of water, following which IOP is noted every 15 minutes for 1 hour. The maximum rise in IOP occurs in 15 to 30 minutes and returns to the baseline level after 60 minutes in both normal and glaucomatous eyes. A rise of 8 millimeters or more is said to be diagnostic of open angle glaucoma. So the basic is nothing but you have um, increased IOP after drinking water. Coming to investigations, first is tonometry. As I showed the pictures, you have applanation tonometry, Chiot's tonometry. Second is diurnal variation test. And the third is gonioscopy. So it reveals a wide angle, open angle of anterior chamber. And optic disc changes we have seen, which is shown by ophthalmoscopy, slit lamp examination of the anterior segment, then perimetry, as I told, with Humphrey's field analyzer to detect the visual field defects, and nerve fiber analyzer, HFA, and OCTs are the recent nerve fiber analyzers. Coming to the treatment, we have medical therapy, argon or diode laser trabeculoplasty, and filtration surgery, which is mainly trabeculectomy. In medical management, we have a wide range of drugs which can be given. One is topical beta blockers, which is 0.5% timolol. It is contraindicated in bronchial asthma and heart blocks. And cardioselective is betoxolol. We have also adrenergic drugs, alpha 2 agonist or 0.2% brimonidine. And we also have carbonic anhydrase inhibitors. Example is 2% dorzolamide. And prostaglandin analogs. Example is 0.005% latanoprost. Coming to argon or diode laser trabeculoplasty, its hypotensive effect is caused by increasing the outflow facility by producing collagen shrinkage on the inner aspect of the trabecular meshwork and opening the intratrabecular spaces. So 50 spots on the anterior half of the trabecular meshwork spread over 180 degrees is given, which will produce opening of the intratrabecular spaces by producing collagen shrinkage. Surgical treatment is mainly trabeculectomy and the indication. So we go for the surgical treatment only when indicated. Initially, we try the medical management, that what are all the drugs we have told. We try all the medical management, and only when it is not controlled, we go for surgical trabeculectomy. So the indications are: one is uncontrolled glaucoma, then non-compliance, the patient is not taking the medical therapy properly, and failure with the medical therapy and they are also not proper for organ laser trabeculoplasty. And the final is eyes with advanced diseases. So with that, we finish primary open angle glaucoma. Now we go into primary angle closure glaucoma. So this is a type of primary glaucoma. Again, it is a primary, which means there is no obvious systemic or ocular cause, in which rise in intraocular pressure occurs due to blockage of the aqueous humor outflow by closure of a narrower angle of the anterior chamber. Coming to the etiology, anatomical factors. So hypermetropic eyes with a shallow anterior chamber, eyes with narrow angle of the anterior chamber, which may be due to small eyeball or nanophthalmus, plateau iris configuration, and age is more common in the fifth decade of life, and females are more prone. Coming to precipitating, so not every time the pressure increases, there are some precipitating factors when the pressure increases. So in an eye that is predisposed to develop angle closure glaucoma, any of the following factors may precipitate an attack. It can be dim illumination, or it can be emotional stress, or it can be use of mydriatic drugs like atropine, cyclopentolate, tropicamide, and phenylephrine. So most of the mydriatic drugs can also precipitate the angle closure, and that is why it is essential to assess the anterior chamber depth before dilating the patient. This is one of the pictures showing mechanism of angle closure glaucoma, where you have relative pupillary block. So once it is attached to the lens and it is stuck onto the lens, it causes iris bombay formation, which leads to appositional angle closure or synechial angle closure. So with this, iris bombay leads to rise in pressure, thereby the angle closes, and all kinds of increased pressure, IOP pressure changes happens, leading to symptoms. Coming to stages, we have latent primary angle closure glaucoma or primary angle closure glaucoma suspect, and followed by subacute or intermittent primary angle closure glaucoma, acute primary angle closure glaucoma, chronic primary angle closure glaucoma, and absolute glaucoma. In clinical features, we have eclipse sign. So eclipse sign indicates decreased anterior chamber depth, and it can be elicited by shining a pen light across the anterior chamber from the temporal side, and noting a shadow on the nasal side. So slit lamp biomicroscopic signs, we have decreased axial anterior chamber depth, convex shaped iris lens diaphragm, and close proximity of the iris to the cornea in the periphery. And gonioscopic examination shows a very narrow angle and Van Herrick slit lamp grading of the angle. Again, we have provocative test for angle closure glaucoma also. So you have prone darkroom test, which is the most popular and best physiological provocative test. In this test, the baseline IOP is recorded and the patient is made to lie prone in a dark room for 1 hour. So he must remain awake so that the pupils remain dilated. After 1 hour, the IOP is again measured. So an increase in IOP of more than 8 millimeters mercury is considered diagnostic of primary angle closure glaucoma. And the other test is mydriatic provocative test. In this, either a weak mydriatic like 0.5% tropicamide or used to produce a mid-dilated pupil, a pressure rise of more than 8 millimeter is considered positive. Coming to the treatment, in both eyes, we do prophylactic laser iridotomy in all the patients diagnosed as latent or angle closure glaucoma suspect. We call it a suspect PACS, primary angle closure glaucoma suspect. So we do prophylactic laser peripheral iridotomy. So this is the picture showing peripheral iridotomy. So they make a hole in the peripheral iris and thereby create a way for the aqueous to come out, so that the iris bombay formation does not happen, and patient will be having free flow of aqueous from the posterior chamber to anterior chamber, and then angle closure glaucoma will not precipitate. Coming to colored halos, so whenever colored halos are seen, the first main differential diagnosis is glaucoma. So what is meant by colored halos? It is seeing colors distributed in the spectrum of rainbow, red being outermost and violet innermost, while watching on a lighted bulb. So this is the same as a uh, rainbow of colors but around a lighted bulb. So differential diagnosis of colored halos are also important. First main thing is glaucoma. Colored halos in PACG occur due to accumulation of fluid in the corneal epithelium and alteration in the refractive condition of the corneal lamella. The other causes are acute purulent conjunctivitis and early cataractous changes. But the diagnosis, first differential diagnosis is glaucoma. Fincham's stenopic slit test. It is a stenopic slit which is passed across the pupil. During this test, glaucomatous hollows remains intact, while a halo due to cataract is broken up into segments. So, which is called as stenopic slit. This is called stenopic slit. Keep it in front of the eye and rotate. So, whether the colored halos are broken or not. According to that, we differentiate whether it is due to glaucoma or cataract. Coming to acute primary angle closure glaucoma, the symptoms include pain, which is sudden onset and very severe pain in the eye, which radiates along the branches of the fifth nerve, and nausea, vomiting, and prostrations. And we have, due to corneal edema, rapid impairment of vision, redness, photophobia, and lacrimation. Coming to the signs, the lids are edematous, conjunctiva is chemosed and congested, cornea becomes edematous insensitive, anterior chamber is very shallow, angle of the anterior chamber is completely closed on gonioscopy, and iris may be discolored, pupil is semi-dilated, vertically oval and fixed, IOP is markedly elevated, usually between 40 and 70 millimeters of mercury. And the optic disc is also edematous and hyperemic. And the fellow eye also shows shallow anterior chamber. Coming to the causes of red eye, we have first thing is conjunctivitis, and the next most common is acute congestive glaucoma, followed by iridocyclitis. Coming to medical management, usually we give systemic hyperosmotic agents, IV mannitol 1 gram per kg body weight, followed by acetazolamide, either IV injection or 250 milligram tablet 3 times a day. Along with that, we give analgesics, antiemetics, and pilocarpine eye drops. Initially, 2% pilocarpine should be administered every 30 minutes for 1 to 2 hours, and then 6 hourly. And any other beta blocker drops like 0.5% timolol or anything can also be applied. Coming to surgical treatment, the same thing, we do peripheral iridotomy with a ND-YAG laser, but we also do in the fellow eye, which also has shallow anterior chamber, and the other thing is trabeculectomy. Coming to Vox triad, it may be seen in patients with post-congestive glaucoma and in treated cases of acute congestive glaucoma. It is characterized by glaucoma flecken, which is anterior subcapsular lenticular opacity, and patches of iris atrophy, and slightly dilated non-reacting pupil due to sphincter atrophy. So all these three things forms the Vox triad. Okay, but usually it is associated after acute congestive attack of glaucoma. So finally we reach absolute primary angle closure. We finish primary open angle, angle closure. Then the end stage, whenever the glaucoma is not treated and it is left as such, it reaches primary angle closure glaucoma absolute stage. Okay, so what it is actually it is painful blind eye. The eye is painful, irritable, and completely blind. There is no light perception. um, and that is no light perception means the vision is absolutely not present. It is also painful and irritable, and it is a perilimbal reddish bluish zone is present, which is due to ciliary flush around the cornea, and the cornea becomes hazy and develops epithelial bullae, which is called as bullous keratopathy, or filaments, which is called as filamentary keratitis, and the anterior chamber is also very shallow. And coming to the iris, it becomes atrophic, and what is happening to the pupil becomes fixed. It fixed means it does not react to the light, or a light reaction is absent. Optic disc will also show glaucomatous optic atrophy because it is the end stage. So almost all the nerves have died. So you have the cup size, optic cup size of more than 0.9, and totally it becomes optic atrophy. And when IOP is measured with tonometer, the IOP is usually high and the eyeball becomes stony hard. Okay. Coming to treatment of absolute glaucoma. So first, as we told, it is a painful blind eye. So retrobulbar, our aim is to prevent the pain for the patient. So whenever vision could not be restored, at least the pain has to be relieved for the patient. So we go for retrobulbar alcohol injection. It may be given to relieve the pain. So what it is actually doing is it destroys the ciliary ganglion. So from the ciliary ganglion is the nerve supply is given to the eyeball. So when ciliary ganglion is destroyed, the nerve supply or the sensation decreases. And then comes destruction of the ciliary epithelium by cyclodiathermy or cyclophotocoagulation. So aqueous is produced from the ciliary epithelium. So when we destroy the aqueous secreted by the ciliary epithelium, it leads to decrease of the intraocular pressure. So this can be done with the help of cyclodiathermy or cyclophotocoagulation. And finally, when nothing can be done and the patient is still having severe problem and pain, so pain is not at all relieved by the conservative methods, then only we can go for enucleation of the eyeball. Enucleation is totally taking out the eyeball, and when it is totally taken, it leads to empty socket, and this thing is there. It is not relieved by conservative methods. We go to enucleation of the eyeball. 2 minutes. 2 minutes. Coming to complications of absolute glaucoma. Complications is when the patient is left as such and the patient is not treated, it leads to complications. So what are all the complications? Due to high IOP, corneal ulceration can be there. So patient can have severe corneal ulceration, and it can get infected, and that will also lead to pain and everything. And due to high intraocular pressure, all the structures are thinned out. So when it is thinned out and sclera is also thinned out, it can lead to staphyloma formation. So according to the staphyloma, we have a site where it is formed. We have anterior staphyloma, ciliary, equatorial staphyloma, posterior staphyloma, and everything. So here the staphyloma is due to thinned out sclera and increased intraocular pressure. So this is also one of the main complications. So once it goes for staphyloma, there are high chances of perforation. So after some time, what happens? Everything shrinks, starts shrinking, like ciliary body, IOP, everything. When ciliary body, so ciliary body is the source of formation of aqueous. So when ciliary body degenerates, the aqueous outflow is also reduced, thereby it leads to uh, decrease in the IOP. And finally, when the IOP is decreased or something, what will happen? The IOP is not there, the eyeball will collapse and it will shrink. So finally it will lead to atrophic bulbi. Atrophic bulbi is the eyeball, everything structures, everything is lost, and it shrinks like a collapsed balloon or something like that, and it decreases in size and everything, thereby it leads to atrophic bulbi. So these are the complications of absolute glaucoma, which happens when the glaucoma is not at all treated and it is left as such. So with this, we finish the glaucoma. So it is we have dealt about primary open angle closure, and absolute glaucoma. Congenital glaucoma is an entirely different picture. So that will be dealt in the next class. And congenital glaucoma is the glaucoma which is present since birth, and usually it mainly increases the size of the eyeball, which is called as ophthalmus or ox eye with the blue sclera, and everything or the same investigations, that is intraocular pressure, disc changes has to be seen. But since it is a child, we see everything under general examination. That is the main difference. So congenital glaucoma or ophthalmus is also a separate entity. Thank you.